You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for June 14th, 2024. This week, some listener feedback, statin eligibility, Yogi Berra, evidence-based medicine and heterogeneous treatment effects, and MRAs in heart failure. I want to first do some listener feedback. So first, on the matter of anticoagulation for AFib after cardiac surgery, last week I lamented the fact that we have only observational data and we don't have trials. Dr. Philip Krasai from Basel University wrote to me that he's on the steering committee of an ongoing trial called Aspire AF, and Aspire AF investigates anticoagulation in patients with AFib after non-cardiac surgery. Now, AF after non-cardiac surgery actually is more common than AF after post-cardiac surgery. So at least we'll have some evidence on the post-surgical AF situation, which comes up very often. Aspire AF looks to be led by the McMaster's team, and I'll offer a clinicaltrials.gov link in the show notes. The second area of listener feedback was on embolic protection devices post-TAVI. Now, on this matter, I covered a well-done observational study looking at the rates of disabling stroke with use and non-use of the embolic protection device. The paper was by Butala et al., and it was in Circ Interventions, and it found a small, borderline significant association of lower disabling stroke in TAVI patients who had the use of the embolic protection device. The authors concluded that their study on more than 400,000 patients, taken along with the 60% lower rates of disabling stroke in the protected TAVR trial of 3,000 patients, quote, provide credible evidence that embolic protection devices benefit patients undergoing TAVI. I had a bit of a different opinion last week on the podcast, namely that yes, there does appear to be a signal for disabling stroke risk reduction with the device, but the situation is actually a classic example where relative risk reduction and absolute risk reductions diverge. In the Butala et al. Paper, the absolute risk reduction is 0.12%, which translates to a number needed to treat of 833, which is obviously a very small reduction for such an expensive and invasive device. Well, surgeon Dr. Sam Hoots from Maastricht University sent me a paper that he and colleagues published last summer in the BMJ journal Heart, in which they did a systematic review and Bayesian meta-analysis of embolic protection devices during TAVI. And I'll link to that paper in the show notes. There have been 7 RCDs that they included looking at embolic protection. The largest is definitely the protected TAVR trial. Now recall that Bayesian analyses are neat because you can look at the probability of A, any benefit, B, the probability of, say, 10%, 20%, or 30% benefit, and then, of course, C, you can combine the prior probabilities with the current data to get the posterior probability. Bayesian reanalyses use probability density functions or curves that look like normal distributions. It's like the prior curve combined with the current data to yield a posterior curve. Then you look at the area under the curve for any benefit, say 10% benefit, 20% benefit, etc. Now, the advantage of Bayesian analyses is that it gives doctors the information that we want. That is, instead of the typical frequentist design where the trialists tell us how surprising the data are given the made-up hypothesis that there is no difference in treatment, For example, the p-value, a Bayesian design tells us the probability of benefit given the data, and you can add in the prior distributions. In the Hoots paper, they use what is called a non-informative or vague prior, basically a very flat probability density curve, one that would not affect the curve of the actual data. When they combine the 7 trials, they find a decent median relative risk reduction of disabling stroke of about 0.55. But the problem is the low stroke rate in a non-EPD group is only about 1.28 or 1.3%, so the absolute risk reduction is just about 0.56 or thereabouts. So they report that there was indeed a 94% probability that the embolic protection device reduced disabling stroke. And that sounds great, right? But the problem is that the probability of any clinically relevant effect was only 0.1%. Now you might wonder, how could that be? Well, they went to the neurology literature and they learned that neurology experts consider a 1.1% absolute risk reduction as the minimally clinically important reduction. So remember that the control arm stroke rate, disabling stroke rate, was only 1.3%. So it's going to be hard to get a meaningfully clinically risk reduction if your control rate is already that low. So Hoots et al. Conclude in their BMJ Heart paper that, quote, there is a high probability of a beneficial embolic protection device treatment effect, but this is unlikely to be clinically relevant. They write that these findings suggest that future trials should focus on identifying TAVI patients with an increased baseline risk of stroke and on the development of new generation devices. Later in the podcast, I will discuss an interesting paper on trying to find these heterogeneous treatment effects within studies. In this case, the question is, can we identify patients at high risk of stroke who may also benefit more from the device? Now, the Butala observational study noted a subgroup of patients who had had previous stroke who seemed to have a larger effect. But even then, in that group of patients, the NNT was still 155, and that is a lot of patients treated with no benefit. And of course, this is a subgroup analysis of an observational study. All right, next topic is statin eligibility. JAMA Internal Medicine has published a study on how data analytic choices affect the prediction of future vascular events. It's a really interesting paper. The implications of the paper are vast, and many of the concepts I've previously discussed on this podcast come into play. But before I tell you about the details, we should remember what the great U.S. baseball player Yogi Berra famously said about prediction. Now, to my non-U.S. listeners, please do yourself a favor and Google Yogi Berra videos and quotes. It will make you smile. There's also a documentary on Yogi Berra that'll make you cry. Yogi famously said, "It is difficult to make predictions, especially about the future." Just saying that makes me laugh. This study 100% confirms Yogi's wisdom. The background here is that the authorities of medicine like to talk about statin eligibility. Numerous experts have devised something called a pooled cohort equation. And in this PCE, patients can enter parameters like age, diabetes, sex, smoker, total cholesterol, HDL, blood pressure, treatment for hypertension, and race, and then that equation kicks out a 10-year risk of an atherosclerotic cardiovascular event. The AHA says that if the 10-year risk is greater than 7.5%, the patient is statin eligible. The USPSTF task force says the cutoff should be 10%. The JAMA Internal Medicine study questions the equation, but I need to point out the folly of even having cutoff values. I mean, it's silly, and it belies the nuance that people generally understand. For instance, what if your risk is 7%? Should you not take a statin? My belief is this. What should happen is that patients be told that if they take a statin, whatever their 10-year risk is, it is reduced by 25% in relative terms. You then take 25% off the absolute risk, and if that sounds good to them, then they can take the tablet. If it doesn't sound good to them, then fine, they don't take the tablet. They should also be told that there's pretty strong evidence that the time with a lower LDL is an important thing to consider, so starting younger may actually be better. All right, a little bit more background. The pooled cohort equation is heavily based on age, so it's super easy to get to above 7.5%. This results in millions of Americans being statin eligible. The authors write that it's about 50 million people. Well, there are also many millions of Americans who don't feel like taking a pill every day. So this results in declarations of vast undertreatment. Also, the pooled cohort equation was derived from cohorts that recruited patients as early as the 1940s, and times have changed. There have been temporal decreases in cardiovascular risk, likely due to many things like less smoking and less trans fats in foods. It turns out, and I feel like a dumb butt for not knowing this, but just last year, the AHA developed a new risk score called the PREVENT equation. PREVENT omits race and includes measures of renal function, as well as statin use and optional variables for hemoglobin A1C and urinary albumin to creatinine ratio, and also a social deprivation index wherein you can input your zip code into the risk calculator. AHA people derive the PREVENT score from an Optum data warehouse, which is a huge data set derived from billing data and electronic health record data. The idea here is that the data set is larger and more recent than the cohorts used to derive the PCEs. More on that later. So the authors applied the PCE and PREVENT scores to a population of about 3,800 adults from the NHANES cohort. The average age, 56 years, about half women, all without heart disease, so this is primary prevention. And get this, the average 10-year risk with the PCE was 8%, but it was only 4.3% using the PREVENT equation. And across all age, sex, and racial subgroups, compared with the PCEs, the mean estimated 10-year risk was always lower using the PREVENT equations. And the biggest delta was seen for two groups, Black adults, and it was 10.9 10-year risk versus 5.1, and older adults from 70 to 75, this difference was 22.8 versus 10.2, so a huge difference depending on what equation you use. The use of the PREVENT equations instead of the PCEs could reduce the number of adults meeting criteria for primary prevention statin therapy from 45 million to 28.3 million. That's about 17 million adults who are no longer recommended if you use the PREVENT. And this would include 4 million people currently taking statins already. So my comments, my gosh, I absolutely love this paper. Yogi Berra was spot on. No one, and I mean no one person, has an idea about the future. I also have no idea if the new PREVENT equation is better than the PCE. Yes, it's more recent and it's larger, but anything derived from electronic health record data makes me anxious. And the reclassification of millions of people does one thing with absolute certainty. It proves the folly of classifying people as statin eligible with an equation. This is just like the Dina Zaretka specification analysis paper that I discussed on the May 10th podcast. Dr. Zaretka and her colleagues at McMaster showed that there are huge numbers of options and analytic choices for evaluating observational studies, and these choices certainly influence the outcome that you get. It's similar to the many analysts one dataset work of Brian Nosek et al. So in the matter of statin eligibility, you can choose your equation and watch your 10-year risk fluctuate all over the place. So I really think the leaders of preventive cardiology need to change this message. Statin eligibility based on an equation is folly. The message should simply be that statins and other primary therapies, such as blood pressure medicines, reduce future risk. By how much in absolute terms, no one knows exactly because no one knows the future risk. See also Yogi Berra. But here's the thing. Most people can't digest a difference in 10-year risk of 4% versus 8%. It's meaningless over a decade. So I stand by my contention, which I learned from Andrew Foy, that there are maximizers, minimizers, and those patients in the middle. People who want to do everything possible to reduce vascular risk can take a statin at whatever absolute risk they calculate at. Minimizers won't do anything, regardless of any equation we use, and most people in the middle can think about it, and doctors may be able to help patients make the best decision for them. Let me know what you think. It's an interesting topic. All right, next topic is heterogeneous treatment effects. This paper is in the American Heart Journal, and there's two authors, Herbert Weisberg and Dailey-Higgs. The title is, quote, Lifting the Veil of Treatment Effect Heterogeneity. Please go read this. It's a great paper. But I know it's a weighty topic. It's different from Yogi Berra and statin eligibility. But figuring out treatment effect is at the core of what we do in the clinic. EBM holds that each patient encounter requires us to mix the best evidence with clinical judgment and patient values. But using the best evidence often means applying trial results, and here's the challenge. Trials output a difference in means as in averages. We get an average treatment effect for the patients enrolled who were treated in that trial environment. And our question is always, does that average treatment effect apply to the patient in our exam room? I mean, take the DANISH trial of ICDs for non-ischemic cardiomyopathy. The average effect was no. But younger patients in that trial had a clear benefit from the ICD. Older patients had a little signal of harm. If we're seeing a 55-year-old with a non-ischemic cardiomyopathy, which do we take? Do we take the average effect that ICDs don't reduce mortality over medical therapy? Or do we take the heterogeneous treatment effect that finds that younger people have a benefit? This was the topic of this American Heart Journal paper. The authors begin by saying most researchers go by the assumption that heterogeneous treatment effects is rare. And that's because statistical methods to detect HTE are conservative. They call it a common effect. And I suspect it is conservative because of the Richard Peto subgroup finding in ISIS-2. Remember, aspirin effects can vary depending on astrological sign, which of course is just statistical noise. So when you look for HTE, you may find noise, not signal. But Weisberg and Dailey-Higgs reiterate that the absence of evidence of an HTE is not the same as evidence of absence of a heterogeneous treatment effect. This is obviously important because it may lead to undertreating certain patients. Now, the authors start with a basic clinical situation, but then they delve into some deep statistics, which I won't pretend to understand completely, but I think the general concepts here is a topic worth thinking about. The authors ask us to consider a 60-year-old without heart disease who's considering taking aspirin. Now, recent data say that there's no meaningful net benefit because the small reduction in cardiovascular events is countered by an increase in the risk of serious bleeding. But, Weisberg and Dailey-Higgs suggest that individuals most prone to an ischemic event may be least prone to a bleed. Such patients could benefit from aspirin. Now, conversely, there may be people who get no aspirin benefit in terms of CV reduction, but they have an increased risk of aspirin-related bleeding, and they should definitely avoid aspirin. So you can see how these populations may cancel each other out, and you'd end up with a null effect overall in a trial. So trials, they write, are analyzed as if there is a common treatment effect, and that actionable heterogeneous treatment effects is impractical to ascertain, or it's random, or it's rare. The authors offer what they label as a straightforward approach for, quote, lifting the veil of HTE ignorance. One issue, they say, is that regulatory trials are designed for approval of drugs, not for finding heterogeneous treatment effects. And they note the history here. Early trials were mostly of antibiotics, and there was a response or not. Averages for those trials told us a lot. But now, as medical science has advanced, chronic diseases have been studied, endpoints become more complex, trials have gotten larger and longer. Now there may be important hidden signals in these trials. Now to the question of individual causal effects. To date, the only way to discover heterogeneous treatment effects is with subgroups. The three issues with subgroups are that A, subgroups only deal with one of many characteristics. Subgroups take continuous data and they dichotomize it, like age greater than 65 or less than 65. And that's so artificial, and is there any real difference between a 64 and a 65-year-old? And of course, the other problem with subgroups is hard to know if any subgroup interaction is real or noise, as trials are powered for an overall effect, not these smaller subgroups. So their proposal, and this gets tricky, but it's interesting. They say the first step is not to determine what exactly the heterogeneous treatment effect is, but whether there is an HTE in some form. And the idea delves deep into causality. And we can all accept that a treatment exerts a causal effect on each individual. So statistically, at least, there exists for each individual an observed outcome, but there's also a counterfactual that would have occurred under an alternative treatment, say placebo. And the alternative they call the potential outcome. So the individual causal effect, or ICE as they abbreviate it, is the difference between the observed outcome and the potential outcome that would have occurred under a different condition, say like the placebo group. The ICE, or individual causal effect, is expressed as an arithmetic difference. The hypothetical outcome for each individual in the treatment arm of an RCT is the sum of their potential outcomes under the placebo and the ICE. What we assume now is that the ICE, or individual causal effect, is constant, or it's small enough not to matter for practical purposes. That's the common effect. But as clinicians, don't you have serious doubts about that? I mean, they offer the coolest example of a trial of a weight loss drug. It's all theoretical, but it's worth thinking about. They contrast two scenarios with this weight loss drug. One is that everyone gets the average 5 kilograms of weight loss. But the other scenario is of patients who lose a lot, a little, and none. And the plots look very different. In the heterogeneous treatment effects scenario, many patients in the treatment arm have no weight loss, but some have huge gains. You have to look at their figure in the paper. And in the short time I've dealt with patients on GLP-1s, I get a sense that there is oodles of HTE with this drug. So in the last part of their paper, the authors propose a way to practically analyze trial data. The idea is that though you can never know individual changes in real life, the trialists could test hypothetical values under any specific model of HTEs by adding them to the placebo group observations. They call this a pseudo-distribution, which would be compared to the observed treatment distribution. Said another way, the basic approach is to display the complete distribution of outcome data rather than relying uncritically on simple summary statistics. They say that modern graphical methods that were unavailable when statistics were initially formulated a century ago now can render fine-grained interrogation of the data feasible. So they propose comparing observed treatment group data to pseudo-data that's engineered to mimic that which you'd expect under a particular HTE model, such as the common effect model. And if there's a discrepancy in the two models, then voila, there would be evidence that there was not a common effect, and that there is likely to be a heterogeneous treatment effect. Now, this sort of analysis doesn't say what the HTE is, it just says it exists and it warrants more study. When this paper came out, there was a robust discussion about it on Twitter, and I sense there's two camps. One camp says that we should only use the average overall effect, and I get that. It's the safest, perhaps the most conservative. But since we are enrolling patients into experiments, I also see the value in trying to extract as much information as possible. And as a clinician, I'd put good money down on heterogeneous treatment effects being common. Come on, some patients take a whiff of antiarrhythmic drugs and never have AFib. Other patients laugh at antiarrhythmic drugs. Some patients respond to PVI perfectly. Others don't respond at all. Perhaps heterogeneous treatment effects is like water to fish. It's so prevalent we don't even notice it. Let me know what you think about this. All right, last topic, heart failure and MRA news. A very nice study in JACC addressed use of my secret weapon drugs, the mineralocorticoid receptor antagonist, or MRAs. Now, when I show slides of seminal trials, I like to go back to the RAILS trial. Spironolactone versus placebo in patients with HFrEF. Spironolactone reduced the primary endpoint of death by 30%. And the absolute risk reduction was a massive 9%. So it was an NNT of only 11 patients, not 800, as in the cerebral embolic protection device. Another important heart failure trial is called EMPhASIS, which compared eplerenone to placebo in HFrEF. Now, since it came 10 years after the RAILS trial in 2009, the endpoint was not death, but CV death and heart failure hospitalization. And eplerenone reduced the primary endpoint by 27%, and an absolute risk reduction was 7.6%. Now, the overall death rate in EMPhASIS was 3% better in the eplerenone arm. Now, one of the main headwinds for using MRA drugs is the worry about renal disease. Specifically, we worry that the MRA drugs will worsen CKD or cause hyperkalemia, so it's easier to avoid them. In fact, few patients with renal disease were enrolled in the trials. Now, this recent paper, first author Dr. Shingo Matsumoto, studied the efficacy and safety of mineralocorticoid receptor antagonist in patients with HFrEF who experienced significant renal dysfunction. They used pooled individual data from ROUSE and EMPhASIS. They then studied the association between MRA treatment and outcomes based on whether or not the eGFR declined to less than 30 milliliters per minute over 1.73 meters squared. And from now on, when I mention GFR, you can assume those units. They used the primary outcome of CV death or heart failure hospitalizations. Before I tell you the results, you should recall the work of Dr. Andrew Foy, who has taught me that just because risk is higher does not mean the treatment has the same effect. In other words, the results of this analysis are not a given. For instance, remember about statins. In the Aurora trial, rosuvastatin, and the 4D trial, atorvastatin, which was done in dialysis patients, the drugs did not reduce CV outcomes despite super high rates of the outcomes. All right, back to the study. The pooled analysis brought in 4,300 patients in both studies, but only 6%, or 300 patients, had experienced a decline in their GFR after randomization to less than 30. These patients had a lower baseline GFR of 47 versus the average of the other patients, which was 70. These 300 patients also had a 2.5x higher risk for the primary outcome than patients without a decline in GFR. But the risk reduction was similar in both groups. For those 300 who experienced a decline in GFR, the hazard ratio was 0.65. For the rest who did not experience a decline in eGFR, the hazard ratio for outcomes was 0.63, so no difference. The absolute risk reductions were also impressive. The rate of the primary outcome was 41 per 100 patient years in the decreased GFR group versus 20 per 100 patient years in the no decreased GFR group. That's a delta of 21 primary outcome events per 100 patient years. The reduction in all-cause deaths was also impressive. It was 34 versus 12, or a delta of 20 per 100 patient years. There was indeed more hyperkalemia, but not that much more. And the risk of hyperkalemia was not modified by having a decline of GFR. So the rate of severe hypokalemia in the GFR decliners was 3.9 per 100 patient years, compared with 1.5 per 100 person years in the non-GFR decliners. Overall, these results translate to this. In patients with a decline in eGFR to less than 30 with MRA treatment, 21 fewer individuals either died from cardiac causes or were hospitalized with heart failure compared with placebo, compared with an excess of 3 more patients with severe hyperkalemia. All right, my comments. This is very nice data. It's probably actionable data. We should not be fearful to use MRAs when there is CKD or if the GFR declines. The expected benefit this paper shows is similar. Of course, we need to always be mindful that individuals are not populations. These net benefits were obtained in a trial setting where you can be sure there was careful monitoring. It's surely more work to use MRAs in the presence of CKD or declining GFR, but the data shows the effect is worth it. Now, the matter of work is not a small thing. When I was at the Beth Israel Deaconess Medical Center a few weeks ago, they told me they were moving to Epic. Now, we've had Epic for nearly a decade, and the thing is that Epic makes it harder to simply order an MRA. You have to type the order in. You have to get the pharmacy right. You have to make sure the labs are ordered for 2 weeks. Then you have to make sure the patients get their labs, and then you follow them up. And then if there's abnormalities, you make more clicks if there is issues. This makes me strongly believe that one of the biggest biases in the hospital and clinic is the matter of how easy or hard something is. Caregivers are overwhelmed, and it's easier to say that CKD precludes MRA use. You don't have to create all this extra work. This is actually why I believe implementation trials are so important and probably the next step in improving heart failure outcomes. So in sum, however, the seminal trials, ROUSE and EMPhASIS, and now this analysis make a clear argument that MRAs are one of the most important things we do for patients with heart failure. And if there's CKD or a declining GFR, we should consider moving on because the benefit is still there and may even be greater. So that's it for this week in cardiology. As always, I am grateful that you listened. Thank you. And remember, if you like this podcast, please consider giving us a rating at whatever app you use. Take the time, write us a 1 or 2 second review. If you don't agree with something I said, send me a note, make a comment on the website. I learn a lot from these comments. Until next week, this is John Mandrola from theheart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.